Present the next session. It is about the Pediatric Radiological Emergencies. Will be presented by my friend or my colleague, Dr. Mohammed Haggag, a consultant radiology and the head of the radiological department in Reem Hospital. Let's welcome Dr. Mohammed Haggag.
And thanks, Dr. Adin and Dr. Anas, for organization of this great event under the umbrella of our beloved Reem Hospital. And today I will talk about pediatric radiology emergency, what every pediatrician should know. What do you see? Yeah, great. Of course you couldn't see, because we are your eyes. And collaboration between radiologist and pediatrician is essential for optimum patient outcome. Timely and accurate diagnosis is crucial to prevent long-term consequences and reduce morbidity and mortality. And radiology play a central role in pediatric emergency, providing diagnostic information for treatment planning. And as you know, pediatric emergency include respiratory, abdominal, musculoskeletal, and neurological. And in Reem Hospital, our radiology department provide all the services, included ultrasound, X-ray, CT, and MRI. And of course, other issues like mammo and DEXA. And I am proud to say that in the last 8 months in radiology department, we did more than 80,000 studies, including all the different modalities. So let's speak about the routine cases come to our clinic every day, the respiratory emergency. And they always come with respiratory difficulties, include dyspnea, cough, and all of these. And the X-ray is the primary imaging modality for most of the acute pulmonary condition. And ultrasound is the first choice in pleural effusion and diaphragmatic motion. And we always follow the ALARA principle, which means as low as reasonably achievable, because the children are very sensitive to radiation, so we use the lowest dose technique needed to reach the diagnosis. So let's start first with the normal chest X-ray. We always see every day the clear lung, clear cystophrenic angles, and the normal cardiac size, and intact bony thoracic cage. So we will start with epiglottitis. What we are looking for in case of epiglottitis, how we can diagnose in the X-ray. Yes, great, thumb sign. And this is the thumb sign, which means enlarged epiglottis. But what about the group? What we are looking for? Great, stable sign, which means subglottic narrowing of the trachea. Another question, what is the common foreign body that always aspirated in children? Coin, it's okay. And coin has two pathways, either esophagus or trachea. So X-ray can help you to detect where is the coin is. In case of the esophagus, in the AB view, the coin will appear rounded, and in the lateral view, it will appear end-on. However, in the trachea, in AB view, it appears end-on, and in the lateral view, it appears rounded. So always remember the difference. If it is in the esophagus, in AB, it will be rounded. In trachea, it will be end-on. This in case if the foreign body in esophagus or trachea. But what if there is small foreign body and it went already more deeper in the bronchus? What we will do? We will make inspiratory and expiratory film. Of course, we talk about the partial obstruction, not total obstruction, as total obstruction will cause lung collapse. So we'll take an example. This is the inspiratory film, and there is subtle hyperinflation of the right lung, especially as lung base. But we will make the expiratory film, there is already partial collapse or partial loss of volume of the left lung, and the right lung still hyperinflated, which means that the foreign body in the right side. This in the cooperative child. But what if the child is young to obey the order, or uncooperative? What we will do? We will make the lateral decubitus, and normally we take images in the lateral decubitus. We will take images while the child on his side, and normally the dependent lung, there is partial loss of volume in the dependent lung. And here, an example for this. There is hyperinflation of the right lung, and on the left dependent, there is partial volume loss of the left lung, which is normal, and right dependent, still the right lung is hyperinflated, which means that the foreign body in the right bronchus. What about pneumonia? Every day, Dr. Ayman, Dr. Bushra ask about pneumonia. We search for opacities, different shape of opacities in the lung, either lobar, segmental, or patches of opacities. And what about the pleural effusion? Ultrasound is the imaging choice for pleural effusion, for detection, for tapping, or the range of the pleural effusion. And as you see here, this is the fluid. This is the pleural effusion, and this is the liver, diaphragm, and the consolidated lung. Can I ask you another question, please? What is the most common abdominal surgical emergency you send every day to radiology department? Appendicitis. Great. Acute appendicitis is the most common pediatric surgical emergency. And of course, the baby will come, or child will come with abdominal pain, vomiting, nausea, and fever. And ultrasound is the imaging modality of choice, because it is non-invasive and no radiation and real time. But what will we see? If you see image for appendicitis and the radiologist said it is appendicitis, how you will diagnose, or what you will see? This is the image, and we will see there is non-compressible distended appendix more than 6 millimeter with second wall. So the cut value for the appendix is 6 millimeter. And also there is periappendiceal inflammation, including fluid and inflamed omentum. Periappendicular fluid collection and inflamed omentum. And we reserve the CT in case of the child for complex cases, like if we suspect perforation or the ultrasound is unconclusive. Always we start with the ultrasound. Don't go directly for CT because radiation. Our children are very sensitive to radiation. Intussusception, as Dr. Shahid said, this is one of the surgical emergency, and it is common between 3 months to 3 years, with peak incidence at 5 to 9 months. And of course, ultrasound is the imaging modality of choice. And we will see concentric layer within each other of bowel wall, which called target sign, or donut sign, or bullseye sign, or are the same meaning. And always remember, if there is absent vascularity in the images, this means ischemia. Okay. Radiology don't diagnose only the intussusception, but also we offer the treatment, as the first line of treatment is air enema reduction of the intussusception, and surgery will be the treating if the enema reduction is contraindicated or failed. And here's short video. Short video for the air enema reduction. We insufflate the air. And here now, this is the filling defect, crescent shape filling defect. We called it close sign. And we continue the insufflation of the air. It will return down in the ascending colon. It go more towards the ileocecal region, and successful reduction will be noted with gush, sudden gush of air into the small bowel. We will see we sustained the pressure. And now, there is sudden gush of the air inside the small bowel, which means successful reduction. Necrotizing enterocolitis, one of the emergency in the NICU, and the plain X-ray is the imaging modality of choice, and we make serial films every 6 to 12 hours, and the ultrasound also has increased sensitivity. What we are searching for in case of non-necrotizing enterocolitis, we will search for air in the wall of the bowel, which means pneumatosis intestinalis, and also can be diagnosed with ultrasound as white dots in the wall of the bowel. We search also for portal venous gas, which appear as white dots at the portal vein branches. And finally, pneumoperitoneum. And in this case, we will raise red flag and call Dr. Shahid for help or support. Testicular torsion is one of the commonest cause of the acute scrotum in children, and Doppler is the imaging modality of choice, and we will see absent or decreased flow in the affected testis, as you see here, and also there is twisted spermatic cord and vessels, which called whirlpool sign. So what about head and spine emergency? Clinical information is critical to select the proper protocol for imaging. And subacute and epidural acute hematoma, we can differentiate by the shape, as subdural hematoma is concave, while epidural is convex. What about meningitis? Meningitis is a clinical diagnosis. It is depend on the clinical and laboratory finding, and also the lumbar puncture. The role of imaging is to confirm the diagnosis, and the most important imaging technique here is the enhanced MRI, as it shows the enhanced meninges. As we see here, the enhanced meninges, and the role of imaging not only to confirm the diagnosis, but to detect the possible complication, like brain abscess, hydrocephalus, extra-axial and intraventricular purulent collection, cerebral infarcts, and cerebritis. Cervical spine injury. We always check the alignment of the spine. In case of trauma to the spine, we always check the alignment of the spine, and also check the alignment of spinous process in AB view, and the space between the spinous process in the lateral view. Lastly, we will talk about non-accidental injury, and it is very important because it is a medico-legal condition, and we always suspect when there is unexplained injury, inconsistent history, or delayed presentation. Complete skeletal survey is the standard imaging in children less than 2 years, and with suspected non-accidental injury. And this is the babygram. And remember, we never perform a babygram. We never ever perform a babygram. This is of medical legal importance, and these images may go to the court. And we make 2-week follow-up to detect the healing of subtle fractures. Middle corner, metaphyseal coronal fracture and posterior rib fracture has high specificity for non-accidental injury, while multiple bilateral fracture and fracture of different ages, complex fracture of the skull have moderate specificity. Long bone fracture and linear skull fracture are common, but of low specificity. Elbow fracture, the most common is the supracondylar fracture, as we see here. But what if the injury is subtle? What we are looking for? We look for the fat bed. The anterior fat bed, which is normally there, and the posterior fat bed, which is absent. Always remember, if there is posterior fat bed, it means it is abnormal. Always it is abnormal. And this is the location of the posterior fat bed. If there is trauma, there will be effusion or hemiarthrosis or hematoma inside the joint from the fracture of the trauma. There will be raising of the anterior fat bed. We called it sale sign. And there is positive posterior fat bed. Anterior fat bed and posterior fat bed. Transient synovitis. This is the most common cause of limping or hip pain in children less than 10 years. And it is a septic inflammation of the hip, mostly or likely to viral etiology. And the child is mildly ill and have history of recent respiratory infection. And it's always diagnosed with ultrasound. We diagnose the joint effusion. The benefit and limitation, advantage and limitation of the imaging modalities, I will go fast through this one. X-ray is best for fracture, foreign body, and pulmonary condition. Ultrasound is the best, of course, for appendicitis, intussusception, pleural effusion. CT is the best for abdominal and thoracic emergency, trauma, and complex cases. MRI, limitation of MRI is long study time, and most of the patients require sedation. And it is already the best for intracranial injury and spinal injury, musculoskeletal condition. Finally, together we can improve pediatric emergency care through evidence-based imaging and teamwork. Thank you.